Hello everyone, welcome back to episode 2 of the Female Edit. This episode I actually filmed a couple of weeks ago. I had the absolute pleasure of sitting down with my consultant, Dr. Denis Tsepov, and we sat down and went through loads of questions that I had. So questions about what is endometriosis, how can you get diagnosed, what are the main symptoms, and yeah, a lot of other things that were on my mind pre-diagnosis and post-diagnosis, because you go on quite the journey. Once you go on quite the journey before you're diagnosed. It took me over 8 years, which is the average right now for women to be diagnosed with the condition. But you also go on this massive journey afterwards, because you spend so many years trying to get answers, and when you finally do, you're like, oh, now I have to figure out what this means for my life. So yeah, we sat down together and went through a lot of questions. I really hope they're helpful for if you're already struggling with symptoms and you're not really sure how to get diagnosed, or if it could be endometriosis, or maybe you've been diagnosed and you feel alone and you just want to know a little bit more about the condition and what your next steps might be. I hope we answer that all in this short video. So we have lots of questions for you.
Of course, yeah. Thanks for inviting me to speak. It's always a pleasure to talk about endometriosis, and especially if we think it's going to help someone to find the right pathway and get it treated. So please fire away.
Yeah. So why don't you tell us a little bit about yourself, how you ended up specialising in this part of medicine?
Yeah, so I was qualified as gynaecological oncologist to start with, and obviously first as a general gynecologist and obstetrician, so I did lots of baby deliveries and lots of labour ward on calls, and became a general gynecologist with subspecial sort of interest.
Yeah.
During my last 2 years of training, I became a part of the oncology team at the UCLH, and basically that got me a very special interest for gynecological surgery, first cancer surgery, and then I realized very quickly that endometriosis surgery can be more difficult, more challenging than cancer surgery sometimes, and I wanted to progress into that area, because that was considered to be a super complex operations, and I realized that sometimes patients are not getting the best surgery if someone is not specializing in endometriosis surgery, and the general gynecologist, that needs a special effort, special skill, special facility, special team for this surgery to be performed in a proper way. So, and that became my motivation to actually go and explore this and become part of it. And with very quickly I became obsessed about it. So when I got my consultant job in Portsmouth in 2010, I joined the endometriosis team there and developed with that team, and in 2015 I took over the leadership of that team, and we really built a very busy endometriosis surgery with multidisciplinary service with colorectal surgeons, urologists, the radiologist, pain specialist, and the whole thing became very, very very successful, and we had lots of referrals from the NHS. And then as I started my private practice in London, so the whole concept was transferred, and I built a very big multidisciplinary team to do endometriosis surgery. It's actually not about just surgery, it's about patient pathway.
Yeah.
It's about getting patient on board, listening to the patient, and then if we think this is endometriosis related, we sort of take the whole journey, starting with diagnosis, and then once we have diagnosis available, we then try and create a map of the disease, see where endometriosis is. Once we identify where it is and what organs are affected, then we discuss how radical, how conservative we need to be, what will be the desired effect, what will be the what's the patient trying to achieve, what's the patient trying to get rid of, like pain or painful intercourse, or infertility, or get the bowel function back, things like this. So it's all patient-tailored service, and that is totally consumed all my interest. So I don't do anything else in life anymore about endometriosis.
Well, we're very thankful for that.
About endometriosis surgery.
Can I ask, well, one, I find it really interesting you talk about that patient pathway and feeling like they're listened to, because I think that's such a big part of the struggle with endometriosis. Like, you feel like you're on this journey for so long where no one understands and no one's listening. So that was one thing I talked a lot about in the first episode, was how for the first time when I stepped in her office, like, someone actually heard me and recognized that I wasn't going crazy in my head. So I think that's amazing that that's tied into that entire journey. You mentioned as well that you feel like the surgery is so complex that not enough people were approaching it in the right way. Do you still feel like today that's still the case, or do you think it's progressed and there are more people looking at the surgery?
Well, yes, so the patient journey is very complicated, because if you're lucky, you get to endometriosis specialist straight away and you take it on board, and the whole sort of journey starts towards sort of getting rid of the disease.
Yeah.
But traditionally, and it's not only UK, it's a worldwide problem. Mm-hmm. So anywhere you go and speak about it, US, Europe, endometriosis has been normalized. The pelvic pain has been normalized just because, and not only by society, it's also by the health professionals.
Yeah. Because
for a gynecologist, a general average gynecologist, the important part is to rule out cancer. If there's a lot of pain, a lot of suffering, is that cancer? If it's cancer, it's relatively easy to detect. Mm-hmm. And then the patient goes to the cancer pathway. The operation, chemoradiotherapy, and everything which goes with it. With endometriosis, as soon as traditionally there is understanding this is not cancer we're talking about, and surgery to get rid of it is quite complex, demanding, complicated, and may not achieve what we want to achieve, then the whole system becomes not so effective unless there is a special clinic dedicated to this complex problem. Yeah. So in a general service, patient often becomes lost and ignored, and from the health professional there is a need to do something useful for the patient, because that's why the patient came to doctor in the first place. Yeah. But then if you can't do anything, and if you don't see the pathway, then unfortunately this disease, the myriad of symptoms it can bring, becomes ignored and normalized almost. So you are a woman, that you have to put up with it, because that's how your periods are going to be until you become menopausal. And hopefully after the menopause, things will get better.
Just need to reach that age first.
I know. And you see, and it can be very traumatic. It apart from the pain and chronic suffering, infertility, it adds on chronic anxiety, mental health issues, depression, and the whole thing just snowballs and becomes a big, huge issue, which sometimes even us, we really, really struggle to put everything in sort of back to normal. Yeah. So that's why the pathway is very complex. But nowadays, and I think we see a very steady rise of awareness with endometriosis due to some brilliant services which have been created in Europe and in UK, and patient groups like Nancy Nook, for example, or Endometriosis UK charity, and these are guys who promote knowledge about endometriosis, and not so long ago it was even mentioned from the Parliament in the UK, and the whole role of societies like British Society of Gynaecological, which is primarily dedicated to endometriosis as a professional society, and the Royal College, sort of part of Royal College of Obstetricians and Gynecologists, the awareness is becoming more obvious, and now we have several brilliant clinics for endometriosis care, surgery, multidisciplinary teams, proper patient pathway. It's all happening, and it's very good news for us, because first of all, we finally got society a little bit closer to understanding, and this is not something people make up. This is severe pain, suffering, which puts negative impact on work, family life, sexual life, childbirth. Everything is affected, and if we have to, if we value our women, then we need to address this.
Yeah, no, you're totally right. A lot of people ask me, and I realise as I talk about endometriosis to people, they have no idea what is endometriosis, and I think you could argue that a lot of people are still trying to understand, even in the medical world, what it is or what causes it. And also, in your perspective, or what would you say the definition of endometriosis is?
I mean, if I'm perfectly honest, we don't have a clue.
Yeah. Okay, good. I thought I was like wrong in that.
On a serious note, so basically, this is the disease where a tissue which is similar to menstrual tissue, the tissue which is built up during the menstrual cycle to either prepare for pregnancy, or if pregnancy is not occurring, it comes off as a period menstrual bleed. So this tissue somehow is appearing outside the cavity of the womb, and it can plant itself anywhere in the abdomen, pelvis, diaphragm, lung, chest, any organ really. And what it does, it menstruates, but it menstruates in the wrong place. So when it menstruates in the wrong place, the body has a special guarding system, like the lining of the abdomen is called peritoneum. And peritoneum is basically a guarding mechanism. So anything goes wrong in the abdomen. For example, like you have appendicitis, so you have pain, you have vomiting, nausea, feeling unwell. So peritoneum sends signals to the brain, this is an emergency, do something. Pain is the signal to do something. So with endometriosis, the same happens. So inflammation without infection is occurring because the menstrual blood is irritant to this lining of the pelvis. So what happens, the pain signal is sent to the brain. The brain, so the patient is in pain because something is happening in the abdomen. So the body then creates a defense mechanism which will, in a very sort of basic terms, it will send a police, which is immune system cells, which are armed with chemicals and all the sort of mechanism to destroy the inflammatory agent, or like a foreign agent. And then these guards come to this focus of disturbance, and only to realize that they can't do anything because these are own body cells. So we cannot attack own body cells because they are ours. So there's no foreign alien sort of mechanism. And what these systems try to do is they create a barrier to localize the disturbance. And that is they create a scar tissue around these menstrual glands, only to see that next month, when the time of the month comes, the whole thing happens again, more scar tissue is built, and it creates like a layer cake anywhere in the bowel, on the bladder, on the ovary, on the uterus. It creates a layer cake with menstrual glands which are abnormally menstruating, scar tissue, another layer of menstrual glands, and the whole thing is turned into a nodule. Nodule is a lump of endometriosis which can unfortunately develop cancer-like properties. It can grow into things. It's not, very rarely turns into cancer. So endometriosis we don't think is a pre-cancerous disease, but it can behave in many ways like cancer. It likes to grow through the organs, it likes to invade, infiltrate, and destroy, for example, the healthy ovarian tissue, or infiltrate into the bowel, the bladder, or obstruct the kidney. And that's what endometriosis is. It doesn't take like a fortnight for this to develop. So we think now about the theories, talking about the theories of endometriosis, that people were born with it. Okay. And once they're born with it, it stays dormant and invisible until you start a menstrual cycle. So once the hormones start going in a cyclical way, estrogen, progesterone, then the whole thing wakes up and becomes gradually manifesting. So if someone starting the period at about age of 10 or 9, and then by the age of 14, 15, they have a very painful period, makes us think, is that endometriosis starting to manifest already? or it's just something which sort of will go away once a girl becomes older and the menstrual cycle is established. So, and that's a dilemma, because the endometriosis in teenagers is very difficult to detect, because MRI scan may still not show much, but the symptoms are overwhelming, and there is a particular sort of a problem. Are we going to operate on all the teenagers with painful periods? And the current culture is no, we're probably not going to do that, especially if they have normal imaging, normal MRI or normal ultrasound scan. So what do you do with them? We put them on the pill. The pill is another potentially problematic area, because if you put it on the pill, which is estrogen and progesterone, then there's lots of evidence now that estrogen in that pill is stimulant to endometriosis, and progesterone in that pill is not suppressant enough. So basically, yes, they will stop the period if you put the pill back to back, but still the progression of endometriosis may be enhanced because of this. And that's, again, poses another dilemma. Sometimes we see teenagers with like proper stage 4 disease infiltrating endometriosis, and that's obviously very unfortunate, because they have a lot of menstrual cycles in front of them, and they want to start a family, and it's already so severe. So,
well, two questions. One, so then is it accurate to say, I have read in places that endometriosis is an overproduction of estrogen in the body, or is that why then that we use progesterone to try and kind of pull the disease back once you're diagnosed?
Well, it's overproduction is tricky, because so you cannot just overproduce estrogen, right? Because yes, you can have estrogen secreting tumor, which will be a cancerous normally tumor which produces estrogen. But that's very rarely is the case. It's very rare to have estrogen secreting cancer, and that's changes the whole paradigm basically. Okay, so I think with a normal amount of estrogen that people produce during menstrual cycle, if you have a target for this estrogen elsewhere in the body apart from the uterine cavity, this is going to have a normal effect of estrogen on menstrual tissue. The problem is this menstrual tissue is not in the right place. It's in the wrong place, but you don't have to have a crazy amount of estrogen to stimulate it. It's just normal amount of estrogen which you produce during the cycle would be enough for it to get going. And if the pill adds on some estrogen, because what pill does basically, it stops production of estrogen by the ovary, because it takes over with the synthetic hormones, estrogen and progesterone, and this tissue reacts in the same way to estrogen, which is a stimulant to endometriosis or menstrual tissue, and progesterone is supposed to keep it under control without sort of stopping the overstimulation, if you like. But then we know that endometriosis becomes resistant to progesterone, apart from the new progesterones which are now available on the market, which demonstrate a very good suppressant qualities to the endometriosis. But it's not that straightforward. It's not about I have too much estrogen.
Yeah, exactly. I was put on the pill quite young for my skin, but I also had really bad periods the minute I started menstruating, and I find that maybe suppressed my symptoms. Like, I never noticed how intense my symptoms were. Maybe the endometriosis actually got worse, and that's when it started to kind of shout at me, or either the pill was suppressing it. Would that?
It's hard to tell, because you see, with the pill it's a mixed effect really, because if the pill stops the period, then if the pain mostly to do with spasms of the uterus during the menstruation, this pain will get better. If the pain is to do with the infiltrating endometriosis invading the nerves in the nerve supply of the pelvis, so this pain may get better for some time, and then it goes back to sort of its normal intensity, or maybe gets worse. So, but there's no hormonal treatment available to date which will make endometriosis go away. You can do something to modify its behavior, I suppress or delay the progression, but there's no pill to date which will make it go away.
And that's why we're here, to try and create that awareness. What are the most common symptoms that you see women come in with? Because there are so many different ones, and I think that's probably why I personally was sent to so many different people. Like, I had the neck of my bladder increased in size because they thought it was that. I seen multiple gynecologists. Like, I had so many tests done because my symptoms weren't like the common endometriosis symptoms. But would you say there are ones that frequently show up, or does it look so different in every woman?
Yeah, so it's really multi sort of symptomatic presentation. Most commonly, it's the pain. The pain is the most common, and the pain can be mild. It can be excruciating. It can be no pain when endometriosis is really end stage and infiltrating into the bowel of the bladder. So the only thing predictable about endometriosis is how unpredictable it is. But most people that we see in the clinic with new referrals will be chronic pelvic pain. Then chronic pelvic pain, if it's cyclical, that is very suspicious for endometriosis. If the pain has a cyclical pattern, that is more likely to be endometriosis related. Sometimes this cyclical pain becomes constant. In this case, we suspect if it was a cyclical, but now it's constant, that means it's probably reached the stage where it's infiltrated into the nerve areas, and the pain cannot be really bothered with menstrual cycles just there, because the offending factors are constant and present. Then the next thing is affected would be function of the bowel or the bladder. So the bowel, the most common bowel symptoms is for endometriosis would be bloating, constipation or diarrhea or combination of the two. Painful bowel motions, that's indicative of endometriosis present either in the bowel itself or on the surface of the bowel. And these symptoms, if they are cyclical, if they are to do with menstruation or premenstrual period, then it's very suspicious. Same with bladder. Bladder can be normal, it can be painful to pass urine, you can have pain when the bladder is full, you can have bleeding from the bladder, and you can have frequency, urgency, a myriad of symptoms. And the problem with this is most of the symptoms are not really specific. Okay, they can affect just about any organ in the abdomen. And patients would normally go through urologist, bowel surgeon, gastroenterologist, up to psychiatrist before they end up with endometriosis specialist. And that's a very typical, unfortunately, that's a very typical journey of the patient. So if you have bowel problem, you don't go to gynaecologist to start with. You go to see gastroenterologist or your GP. I said, you do colonoscopy, it's normal, so we don't know. Try the probiotics or try and exclude this from your diet and that from your diet.
Or some
Buscopan, diary, and just eat whatever you fancy eating. And it's funny, but we see people who cut down on so many pleasant food. And they call it healthy diet. It's not healthy diet because they're very limited what they can actually eat without causing a major upset to their abdominal digestive system. So it's very sad.
I'm smiling because everything you say is just so familiar. It's just literally what happened. You kind of touched on it, but why doesn't it show in an MRI, or what percentage of diagnosis would you say does show in an MRI before going in with
it's ongoing debate. So with endometriosis, so in our center, so if someone comes with endometriosis symptoms, and we have a very detailed questioning before we decide is that looking like endometriosis or not. If we think this is symptomatic for endometriosis, then we request MRI for everybody who is symptomatic. So MRI is a fantastic tool, but there are some nuances to it, right? First of all, it has to be a very special MRI. We need to stop the bowel moving during the MRI, and we use the old good Buscopan to do that. And the difference in quality of the image is stunning. Seriously, when the bowel is constantly moving, it becomes a blur. If the bowel stops moving, and we need to stop the bowel moving like for half an hour, 40 minutes max. It's very clear image, and if endometriosis invades the bowel, then we'll see it immediately. We can detect 3-4 millimeters into the bowel infiltration with this MRI. So it has to be a special MRI with contrast, with bowel immobilization, and more importantly, you have to have a radiologist who would have special interest in endometriosis, because most radiologists reporting gynecology MRIs are looking for cancer. Okay?
Yeah.
And that's fine, because they're very skilled, they're very good in detecting cancer. They want to stage the cancer on MRI and CT. With endometriosis, slightly tricky, because if there's no cancer red flags, then you say, this may be cancer, maybe not. But maybe endometriosis, maybe not, we don't really know. But if you find a specialist person who reports endometriosis as a radiologist, then the chance of them detecting the disease is very high.
Yeah.
Okay? So endometriosis, which is deep infiltrating, which is lumpy or cystic or grows into the organs, is detected on the MRI very well with a specialist approach. Endometriosis, which is fluffy on the surface of the organ, and maybe like scattered around the pelvis, may not be seen. It's just because it's too fluffy for MRI to pick it up.
Okay.
And so we know that the reason we do MRI, so if it comes positive for deep infiltrating disease, we know what to expect.
Yeah.
We know what team should be present in the operating theatre, not only gynecologist, but also a colorectal surgeon, urologist, thoracic. But we know also that this patient will need extensive surgery, so it's kind of just a little look-see laparoscopy, and then, oh my God, we didn't know about this, you know.
Yeah. Yeah.
So we avoid this because we have this detailed map of the disease.
Yeah.
If MRI comes back negative, but the symptoms are pointing towards endometriosis, what we do, we still offer laparoscopy, and most of the time we find endometriosis, which is not seen on the MRI. It can be with degree of superficial, sort of minimally invasive, but we have maybe 2-3 laparoscopies per year where we don't see endometriosis in a symptomatic patient. That's very rare, very rare. And but most of the time, if we have symptoms, even the MRI is negative, we still offer look inside, and most of the time we find endometriosis to treat.
Yeah, because I had 2 MRIs and neither showed how much I had. So
yeah, it's because it's a fantastic tool, but it has limitations, like everything.
Like everything, exactly. Okay. Thank you so much for watching episode 2. I really hope that that episode was helpful and answered some of your questions that are maybe on your mind. I continue to be amazed at how complex the condition is and how little knowledge and how little research is actually out there on endometriosis, what it is, what it causes it, and how it impacts so many women. I will drop my consultant's details down below for anyone that maybe wants to work with him or schedule an appointment. And in the meantime, let's continue to raise awareness. Let's continue to share our stories. Let's continue to push for answers, sending massive amounts of love to anyone that struggles with the condition or is trying to get answers. But yeah, thank you so much for watching. Bye.